I'm Dr. Richard Krasuski from Duke University. Today we're going to talk about the rapid escalation approach to care and mainly focus on the rationale and the clinical evidence behind it. So on our first slide, you can see here is a patient who has fairly advanced function class 3 symptoms. Their initial therapy starts, and within 30 days, you're already planning and subsequently adding on a second therapy. You can see that we look at it for an improvement. Patients start to improve, but they really haven't reached their goal. And so you add on a therapy here, roughly about 6 months or so later, again, trying to get them to their goal and already having a plan of adding on therapy regardless of how the patient does and unless they fully achieve their goals for that third agent. So ideally, again, we are dealing with a disease that affects many different pathways. If we use multiple pathways, we can try to reduce the toxicities potentially of some of these agents. And in fact, there are some effects that are additive to one another. And so you can see here are the three main pathways that we focus on for pulmonary hypertension. On the left is the prostacyclin pathway. In the middle is the nitric oxide pathway. On the right is the endothelin pathway. We have drugs that target all three of these. And often the use of combination agents early on in the disease may have a significant impact on clinical outcomes. So let's talk about the major study that shows evidence for this strategy. And here's the AMBITION trial. So in the AMBITION trial, there was monotherapy or combination therapy. So basically patients could be placed on either the endothelin receptor antagonist, ambrisentan, or the PDE5 inhibitor, tadalafil. Or they receive both the medications up front. And you can see that if they receive combination therapy up front, there was a statistically significant reduction in clinical events. You can see it's roughly about a 50% reduction here by the end of the study. So clinical trials such as, in addition, SERAPHIN, GRIFFIN, and AMBITION, and others demonstrate the merits of combination therapy. A number of the patients in these trials were already on upfront therapy, and then they had the addition of an additional agent, basically, to try to get them closer to their goals. Initiation of combination therapy is now recommended for patients who are not responding adequately to monotherapy. And recently, there has even been a trial looking at triple combination therapy up front, consisting of epoprostenol, bosentan, and sildenafil in patients with New York Heart Association or WHO function class 3 or 4 and severe hemodynamic derangements. So the central question here is, for this trial was, does triple therapy provide enhanced survival benefits? And in this particular study, we clearly had evidence that it affects clinical worsening, and it appears that probably this will translate to better outcomes as well, but further trials are necessary to determine that. So here are the results of this trial, and you can see the baseline function class was 3 or 4 in the patients, and you can see by the 1-month follow-up, we had one patient that was function class 1. We had 16 of the patients who were in function class 2. Only one was in function class 3, so a rather substantial improvement. 6-minute walk improved. The hemodynamic parameters all improved, and you can see the dose that was achieved here, a reasonable sized dose of epoprostenol. And by the follow-up visit, final follow-up, there was again evidence that the improvement that was present early was maintained through the end of the study. So which type of patients would you then consider this kind of combination or induction type therapy where you give multiple drugs up front? First of all would be you want these patients to be moderate to high risk. There are obviously some downsides with these medications, including all the different side effects once you combine a variety of different agents. Again, patient assessment should happen early in the initial treatment course, roughly between 1 and 3 months. You don't want to wait too long when you start these medications. If the patients aren't clearly in or moving towards a low risk category, you should consider escalation of care, perhaps adding even an additional agent or IV prostacyclin if they're not already on that up front. So in summary, we've talked about a induction type of therapy where we look at aggressive upfront combination therapy. The AMBITION trial clearly shows a benefit of this particular approach compared to monotherapy. So in some patients, particularly those that are moderate to high risk, this is a very reasonable approach but still one that requires monitoring these patients closely afterwards to see how they're doing. I thank you for your attention.